It is my pleasure to introduce Topher Jerome as our final speaker of the day, who coincidentally I know and have, spent a good amount of time with in advocacy together. He has an amazing story and message. Topher brings lived experience, and as such, we are very pleased to have him with us today. A quick reminder, this presentation will have automatically generated captions. To view them, just click live transcript at the bottom of your screen and follow the instructions there. Mr. Jerome is a product director for Harborview Behavioral Health Institute and Lived Experience Advisory Board chair at Jasper Health. At the Behavioral Health Institute, he implemented and manages a SAMHSA grant funded sorry, I got thrown off. There were some noises here, but we're okay. He implemented and manages a SAMHSA grant funded COVID-19 emergency response for suicide prevention program for emergency departments and inpatient psychiatric settings in Washington. This program combines post-crisis peer support with the use of the Jasper Health app. Mr. Jerome spent 12 years developing, implementing, and supervising a variety of peer support programs in intensive psychiatric settings. This includes the implementation of peer bridger programs in 2 publicly funded hospital psychiatric programs, and serving on the leadership team for a community behavioral health agency. As a multiple suicide attempt survivor, he brings a personal commitment to his work in suicide prevention. Topher, thank you so much for sharing your expertise with us today. The floor is yours.
Thank you, everybody. Thank you, Bill. Nice to see you. Thank you, everybody. I'm trying to share my screen here. Please stand by. All right, hopefully everybody can see that. Yeah, so my name's Topher Jerome, as Bill said. He gave a great introduction, all my various bits of experience that brings me here to this chair today. I'm really grateful to be asked to do this. And it's also one of those things that was like, what was I thinking? Which is sort of my cycle, with these kinds of things. I choose to be open about having lived experience with mental health, substance use, and as a suicide attempt survivor for multiple reasons, but primarily it's to help people understand that it's okay to talk about it, it's okay to have it, it's okay to live with it, and to reduce stigma and to help keep the conversation open and help people know that there's a way through the shame. So today we're going to be talking a bit about really the power of story, how peer support can be super effective in building trusting relationships and inspiring recovery. I'm going to talk about the Jasper Health app, which is part of the Emergency Response for Suicide Prevention project we're doing because it demonstrates how peer support can also be delivered through technology. And I'm going to talk some about implementing peer programs, including adopting funding challenges. Peer support's about story. It's about connection with somebody who has similar experiences. And so I'm going to tell a little bit about my story. I am the youngest of 5 children. My parents were both alcoholics. There was mental illness. I was raised on a hippie commune in the Appalachian Mountains, which, there's a lot of things in my story that are similar to others, and that one's kind of unique. I was raised around drugs, alcohol, abuse, sexual abuse, all this stuff. I was the youngest, right? My parents didn't really like children, and I ran across this thing a few years ago 20 years after my father died. I found it online, and it was like a ghost talking to me from the past. But he said that he was disgusted by children because they exploit adults to pay attention to them. And that really brings, that was like, okay, there's proof, there's written proof about some of the stuff I've had to deal with in my life. And, I wasn't sent to school. I was illiterate as a young teenager, and I carried shame. I carried shame about that. I carried shame about who I was. I had a really hard time being in the world. I started using drugs and alcohol at about 11 years old, and that that helped. It helped. It's just like, oh, I could be in the world that way. Part of this whole story that I want to connect to, which comes into play later, but it's like I had to be a good little boy. I had to be a little adult. I had to be, I needed to have the grown-ups in my life think I was okay. And so, not a unique thing to me, but it's super challenging for me, because as I got into later in my life, as my early drug and alcohol use started to take off, somehow, just fast forward a couple chunks, somehow I was able to go to college and get a degree, which was kind of a miracle. I learned somewhere along the way that I wasn't the stupid person I thought I was, although sometimes I'm still challenged with beliefs from time to time. But what was happening for me is the more I got into addiction and undealt with trauma, undealt with PTSD, my mental health stuff going on, as things started to pile up, I was having a harder and harder time hiding what was going on for me. And all of a sudden, I couldn't be the best little boy anymore. I couldn't hide it. And I started disappointing people. And once that started happening, the shame kept building and building. And I could not stand the thought of what people were thinking about me, especially those who were close to me. And that led me into suicide. I'd lived with suicidal ideation for years and years before I actually made my first attempt. And it was always this thing I just sort of had stashed away that I could do at some point when it got bad enough. And, eventually it did. It got bad enough. So the connection between addiction and shame and my suicide attempt, financial ruin, all of this stuff comes together because it led me to a point where I was at this point where I was going to kill myself again. And I made this promise to my family earlier on after a really serious attempt, that I wouldn't do that. And I couldn't stay clean and sober, 9 treatment centers. It just goes on, inpatient psych, in and out. And I couldn't stand my life. And so that sort of forced me into this thing. It's like I had to get into recovery. I just had to do it. And I had to do it with an earnestness if I were going to make it in this world. And it was in that my life really started to unfold in really interesting ways. This idea about what led me into peer support work happened. I was in 6 inpatient treatment centers, 9 outpatient. So it was my 9th outpatient treatment center. I was like, why should I go? There's nothing they can tell me that I haven't heard already. But I went because I was committed to this thing. And we're in this small group, and it's at the end of the however many weeks it was. And, when people do their graduation things, they sit around and everybody says something nice to them. And I'm going around and, everybody's saying, nice things about me. And I got to this kid who I'd never spoken to throughout the whole course of the program. And I had nothing in common with him. So I thought, and he gets to me and he says, "You changed my life." And I'm like, "What?" Never even spoke to you. He said, you have given me permission to say what's really going on with me. And whatever the words he used at the time, that was the meaning. And it was like, oh my God, it just stopped me in my tracks. It was like, there's something about this that's important, right? That I have a gift that I can offer people. It was before I knew about the peer support profession, but it was like, I need to get out of IT work. I need to do something different. And I found peer support, and that's what entered me into the field. I'm going to talk about stigma later, and I'm going to talk about my work around expanding peer support later. I do want to say that being in peer support is really important to take care of myself. That for me looks like support has looked like for a long time. I go to 12-step meetings. I've done that for years. I'm in long-term sobriety now. I have my husband and my community who I tell the truth to also comes up later. And I have a therapist I go to regularly. I have a job which provides meaning and support. And I have a spiritual life. And I stay engaged in physical fitness. And so all of this is super important because when you're working in the peer support world, I'm in and around suicide every single day. There's not a day that goes by that I don't think about my own story, right? It's really important for me to take care of myself because I didn't before when I started working with in this suicide specific field, and I started getting suicidal. And those are things that I have to pay very close attention to. So the power of connection and peer support, I think everybody knows now the peer support are people who have lived experience with behavioral health challenges, mental illness, suicide, substance use. And peer support isn't limited to those topics. You'll think about breast cancer survivors or people who live with diabetes or, you name it, right? We have peers out there that we can relate to in a way that other people, because we get it. And I've had this experience so many times over the years where I'm sitting with somebody and where they're sharing something and I have the ability to share something back, because in the peer support world, you use your story judiciously as a way to engage, a way to help the person know you get it, to help build trust. And I'll tell you, that trust happens so fast. It's like, oh my God, you get it. And this light comes on in people's eyes. It's like, oh, you're okay, right? I can believe that you're okay. And it doesn't happen with everybody, but it happens a lot, and it's super powerful. I get goosebumps when I think about this stuff. And for me, it's kind of a spiritual experience when that happens. I think one of the other really important parts about shared experiences is that when people really get it, they're able to it's easier to be open and honest. I mean, I've been a mental health patient for years, on and off, and I know how to tell people what it is they want to hear, right? I know how to get into psychiatric hospitals. I know how to get out of psychiatric hospitals, right? It's so many of us who've been in the system get this, right? And so the idea of when I'm telling people what it is they want to hear, right? For me, a lot of times that even happens in my personal life. When I tell somebody I love, who I trust, that I'm doing okay when I'm not, because I'm worried about what they think, there's my first warning sign that something's going on, right? So in the world of peer support, I actually pulled this into today. I'm the project director for this program. We are tight on staffing. We have a lot of numbers, so I'm carrying a caseload, which is incredible because I'm in touch with this work that we're doing in a way I haven't been for quite a while. And I'm talking to this guy today, and they'd mentioned that they almost went to the hospital, but then their therapist decided that they didn't need to. And I said, so did the therapist decide? So I said, well, what did you tell the therapist? I said, did you tell them the truth or did you tell them what they wanted to hear? And we both laughed, right? Because we get it. It's like, it's like we can call each other on this stuff sometimes. And he said, honestly, it's both. He says, I'm not going to do anything, but I know if I say sometimes, then I'm going to get locked up, and that's not what I want, and that's not what I need. So it's fascinating how that works, and probably all the clinicians in the room are going cringing, um, but there's laughter and connection and mutuality that happens. And the other thing about peer support specialists is they work in a huge variety of roles, or we work, I should own that. From leadership, I'm in a leadership role, right, to people who are in our emergency response to suicide prevention program, doing suicide support. There's peer bridgers transitioning people out of inpatient hospitals into the community. There's people who are working in community mental health centers, leading groups, helping people run errands, taking them to appointments, and employment support services. So peer support's used all over the place. And one of the cool things is that many of us have learned how to navigate the system. I was never part of the publicly funded system myself, so I don't have that experience, but a lot of peer specialists have been, and they know the intricacies of navigating the complexity of those systems, and that helps that person move forward in their journey in really important ways. So kind of getting into this a little bit more, I stole this from a presentation I did years ago, actually. But I think it's a nice illustration because you look at sort of traditional clinical support and along with sort of what peer support, how peer support fits into that. And I really think about this kind of going from the objective into the subjective, right? So if you look at, case management, traditional support like that, you're looking at really some of the basic needs, shelter, food, clothing, hygiene, accessing medical, reducing hospitalizations, incarcerations, stabilizing systems, harm reduction with substance abuse. So that then we start moving more into the subjective, like quality of life. It's like higher level of basic needs, learning to keep your place clean or neat, or having a place where you can actually decorate or find things to decorate with, right? No hospitalizations, no incarcerations, personal relationships start to change. Normative activities, I kind of hate that term, but anyway, things that we all do to make our life meaningful. And, just caveat here, it's like, I've got to have a life that I want to live in order to live it, because I go to suicide really easily. And if I don't have that, there's not much that's going to keep me alive, right? So it's really so much about this stuff is, we get so much of the work that has to happen in these settings that we're doing is about the basic needs. We've got to get this, this stuff taken care of, but really to help somebody move beyond into creating, a satisfying life is so much more than that. And, and so the beauty of peer support is, as people have lived experience, one, peer supporters often have the time to work with people. They can help them get connected to natural supports. There's all this stuff that they can do together that's beyond the basic needs. And the more they do that and built around this trust and mutuality in the relationship, it takes the pressure off of the clinical support, hopefully reducing over-reliance on the traditional support, and start to build self-reliance and to help enable them to have a life that's worth living, which is a big deal. So I'm talking faster than I intended to, probably because of nerves. So I'm going to try to pace myself a little. The emergency response for suicide prevention program, grant funded through SAMHSA in partnership with the Washington Healthcare Authority, is a 16-month grant. It ends this end of this November, so we're winding down towards the end here. And what it is there's ERSP programs throughout the country, and the idea was, how can we do a systems change innovation project to address suicidality in the COVID era. And so what we're doing, this grant was written before I came to work at Harborview, and little caveat in my story here, pause here. I worked at Harborview for 3 years in information technology. I blew up my life, came back, worked in peer support, started as peer support specialist, then started all these programs, worked in mental health for 10 years there. I left, I went off briefly to King County to start a peer bridger program in partnership with other regions in the state at Western State Hospital. And then I went to work for this small tech startup called Jasper Health. Amazing people, amazing project. It was grant funded through NIMH to build an app to help people who are suicidal while they're waiting in emergency departments. So I did that for a couple of years. During this, the collaboration between all the involved parties was to develop this peer emergency response for suicide prevention proposal, which is using the app that we've created at Jasper Health along with peer support. So really marrying the two together. So when they got the grant, for me, going back to Harborview was incredibly, was very exciting opportunity, because one, I loved Harborview. I worked there for many years. I know it inside and out. They saved my life. I was hospitalized for 6 weeks once with huge debts I could never pay back. So I always feel somewhat indebted to it. And it's a passionate about suicide prevention. So I came back to Harborview to do this project. So the whole point here is what the project is. The app was developed to help people who are suicidal while they're in the emergency department. What we're doing in this project is we've moved it beyond, also in the emergency department. We're working at Harborview. We're working up in Stevens County with 2 Providence hospitals up there, with Northeast Alliance Counseling, which is their county-run inpatient psychiatric facility. And so we started with these organizations, Harborview Emergency Department and Inpatient. So we're looking at urban and rural, delivering the app at the point of care, right? So using the app to engage with the people who are experiencing a suicidal crisis, and then adding peer support. So providing post-crisis follow-up support with peer specialists who are especially trained with suicide care, with and well-versed in the app. And so much about what the app does. There's a suicide status interview, which is all based on CAMS, helps facilitate lethal means counseling, suicide safety planning, has hours of people's lived experience videos. And I'm going to show a little demo of the app, actually, so I don't need to spend too much time on this. But providing this peer support along with it. And so the goal here was to provide the support after somebody gets out. And I was really started thinking about this when Abraham was talking this morning about his wife, and God bless you for sharing your story. And thinking about times that I got out of the inpatient facility, whether it was chemical dependency or mental health, and feeling like I just fell off the cliff of support, kind of like, is that it? People wash their hands of me and now, okay, go here's an appointment, at some point go to it, you know, and this idea of being met with caring people who understand, who help me through this transitional period afterwards. It's like, to me, it's a no-brainer. Why don't we do this everywhere? Why don't we do this all of the time? Which is why I'm really excited about this project. So I just lost my train of thought. So anyway, so what happened in this project is we started out with these sites. There are contracted sites, but we have opened it up to, we take referrals now from anywhere in Washington State. People are over 25 years old, which is SAMHSA requirement, somewhat challenging because there's a lot of people younger than that that need it. And people make referrals. So the support looks a little differently based on where they're coming from. In Stevens County and elsewhere in the state, the peer support is all virtual. It's over Zoom, telephone, you know, however we can figure out how to connect. They use the app in the setting, and then they have peer support afterwards. If it's from elsewhere, like say we're working with Providence Telepsych, you know, we get referrals from them, and then they don't have the app, they're all virtual. So then our peer navigators use the app virtually with people, help them build the stability plan, do the lethal means counseling, and then use the stability plan that's in the app as a touchstone for each of their subsequent meetings. And they meet generally once a week or so. For, you know, it's open-ended kind of, you know, now we're getting closer to the end of the grant, so that time's more limited. And then at Harborview, they're embedded in the inpatient units and the emergency department. So they're actually using the app with the person on the unit. So the settings are different. I mean, it's a different strategy for the different settings. So anyway, so I'll come back to that in a minute. So I'm going to take a brief sidestep because I want to show you a little bit about the app. Here, let's see. Do a new share. And okay, let me just lock me out. Okay. So the app, you know, originally designed to be on a tablet. We're using it in our program, like I'm showing you here over the web a lot. Has 4 primary sections. There's the suicide status interview, which I described, you know, as the CAMS interview, and that's led through a virtual agent. So it's a text interface. You know, it looks like a text chat with a chat bot. The shared stories section, I'm going to dive into these briefly. I do want to show you a shared stories video, or at least about 1 minute, 20 seconds of one, just to give you a sense of what they're like. Because this is about peer support and it's about connection, the story of power of connection. You know, I did a lot of the bedside testing and research as we were developing the app at different hospitals around, especially in the Midwest. And I got to see firsthand how people who are struggling responded to these videos. And the magic was very similar to when I've experienced it as a peer counselor providing support, right? People would talk about, oh my God, they're talking to me. Oh my God, I didn't know. I no longer feel like I'm alone. There are other people like this. Are you kidding me? This is life-changing. You know, I'd hear all of this stuff, which just reinforced, 1, the idea of story, and then 2, the idea that this can be delivered in other methods. I don't want to take the peer counselor out of the picture by any means, because it's critical to have that, that in-person support. But when you look at rural communities that do not have access, this is something that's super powerful. And then you have the telehealth version of the peer counselor working with them. So anyway, there's a whole variety of topics. People's stories, my wish for you. I love the my wish for you category, up through shame, emergency department, supportive people, what it's like going home, all the way down reasons for living, creating a life worth living. And then we have a fairly broad variety of demographics representations. There could be many more. We're actually working on some when I left. Anyway, so then these are all cross-referenced. So if they go in and they listen to somebody's story, it's like, oh, I really like Kalichi. Then they can click on Kalichi here. And actually, I'm going to go back here for a second. And then they can go to her. This is where I was going. And then they can see all the different topics she spoke to. I'm going to play a minute or here. Let me see if you can hear the audio. Can you hear the audio?
We can't, but if you click on the share screen button and do the share computer sound, it should play.
Yeah, I realized I forgot to do that. Okay, try again.
My life before the emergency department was pretend. I pretended to be okay. I pretended to be happy. I just tried to make everyone feel comfortable, and I was breaking down inside. And, you know, when something traumatic happened, I could no longer pretend. I had to break the mask, and that led me to a suicide attempt. Once I was in the emergency department, I did make some decisions. I was really tired of living a lie, pretending that things were good when they weren't, really struggling with depression and just thoughts of self-harm constantly and stuffing everything down. Once I was in the emergency department, all of those feelings towards myself of hatred and disgust, you know, they kind of marinated and were really big. And once I left, I decided I need to find out what are these lies I'm telling myself? Why am I saying I'm not a good person? Why do I believe that I don't belong here? What is going on to make me think that this person in front of me isn't worth it? And I wanted to interrupt those thoughts because there's a reason I survived, and I decided to figure out what that reason was. What my life now is.
I just love her. So anyway, that gives you a taste of what the video's like. There's over 60 videos in here, 2 to 4 minutes in length. And then just super briefly, there's a comfort and skills section, which are psychoeducational skill buildings, things to distract. You know, doing the testing, 9 times out of 10, people go straight to puppies. Watching somebody who's in a suicidal crisis in the emergency department start to laugh, you know, at this thing, it's like, it just changes the whole experience for them. Then there's skills that are taught both by people with lived experience, sharing how they've used the skills themselves. And then there's a whole series on mindfulness from Marshall Linehan. Thank you to Now Matters Now and Ursula Whiteside for enabling them to use the content. And there's just starting to build out a library of videos for loved ones. So again, it's peer support, you know, talking about what it's like to take somebody home, or, you know, understanding the levels of care, what, you know, that type of thing. And then the takeaway kit, you can set up your Jasper at Home account. So there's a companion smartphone app that has the full stability plan, which I don't have it filled out here, on the phone. It has a distress survival guide. So you push the distress survival guide button and it pulls things from your own customized stability plan in a step-by-step, one-by-one, easy interface to try to walk you through the crisis that you're in. You can favorite videos and all of that stuff. It shows up on the app on the phone, where you have content. You have access to all the content that's here in the app, both on your phone. And then there's a suicide crisis safety plan. This is, I'm not going to go through this just in the interest of time, but this chatbot walks you through in this case, I just chose the lethal means and the suicide stability plan. But it would walk through that interface to do that. So that's the app. I'm going to stop the share. Let's share screen again. Back to the PowerPoint. Okay. So the ERSP, going back to the ERSP program, the response from people, we're still, collecting data, so we don't have the data outcomes yet, but the feedback we're getting from participants and providers has been really powerful. And I think it's worth just highlighting some of these examples. This first one over here, it's like I had a conversation with my social worker back when a time when things were difficult to handle, and it triggered a lot of anger, and I wasn't going to my appointments after that. I thought of one of the videos we watched together last week, and it just had it in the back of my mind, and I was able to stay calm when I met with my social worker this time. I felt happy. I shared this with my social worker, and she said I'd made her day. I'm eager to watch the videos you're going to show me today. So that is the peer support, peer supporter, peer navigator, we call them in this program, using the videos in the app together with the participant. You saved my life on multiple occasions. I don't know where I'd be without you. I love this one down here. I was a wilted flower, and now I'm at the start of my journey. I have jasper, and there's a upright flower. I'm blooming. I'm alive. Thank you. Watching videos, do people remember it later? They used it to get through a moment. So it's this stuff that is amazingly powerful. We hear it's like, oh, I would have gone to the hospital, but I have you, and so the peer supporters are working with the peer navigators are working with people in really unique ways. Like one of them has Daniela, she's doing a mindfulness challenge with a lot of people. So they have daily text message. She has daily text messages going on with people, just super creative ways about engaging with people, helping them know they're supported, using the sort of caring contact model, but sort of on a more, because there's in-person contact, but it's providing this support continuously after they've gotten out of the hospital, to help move them on, hopefully, to the next stage in their recovery. So just briefly, the peer support as a profession has been in Washington State since 2005, and I'll just stop there. It's been going on much longer than that. That's when it first became Medicaid. You're able to build Medicaid. That's when the official trainings came out. But, I think back to my early 12-step experiences, right, where I remember sitting in a meeting and struggling with, alcoholism and addiction, and somebody talking about, that they hid bottles, and I had no idea. Other people did this, right? And I just was floored. It's like, oh my God, you do that too, and all of this, so that power of connection, it's been going on, in 12-step world for a long time. And it's been going on, who knows how long before that. So there's been over 3,600 people trained in Washington State as peer counselors. They're not all working as peer counselors, but the training has been completed for those people. There's standardized training is administered through the healthcare authority. There's 3 different training pathways. There's one for adults, so that's primarily, that's the world I've worked in. There's a youth and family track for people who work with the WISE programs, and both family members and youth are trained to provide peer support. And then there's a bridge training for recovery coaches. So recovery coaching is a training that is it was geared for substance use. And in 2019, substance use peer support became Medicaid reimbursable. And so they made a 3-day training for to help recovery coaches become certified peer counselors. The peer counselor training is you do a 10-hour online prerequisite, and then there's a 40-hour training that's either done in 1 week or 2 weeks, depending on if it's virtual or not. At the end of that, you get the certification, and then the agency that you would be working for can, that becomes a reimbursable Medicaid service. So I want to talk a little bit about stigma. This has to do with peer support, and it has to do with serving the people that we all are working with, and it's an important thing. I had this experience when I first became a peer counselor of, I decided I was going to do this. I'd been in IT at Harborview, and I used to support the mental health clinic in clinical information systems. When I decided to get into peer counseling, I applied for a job at Harborview in the mental health clinic. And I remember the hiring manager, this was, 16 or more years ago. It was a long time ago. And the hiring manager, is this Topher? Yeah. Topher who works in IT? Yeah. Do you know what you're applying for? And I said, yeah. You have to have a, mental health, yeah. And it was just such disbelief. And I felt embarrassed. I was like, oh God, how could I be doing this? That was really interesting. And when I started that job, I walked in with my tail between my legs. I was embarrassed that I was doing it. I was embarrassed that I was being open about living with a mental health challenge. And I think about what would have happened if he would have said, is this Topher from IT? Yes. Oh my gosh, we need professionals like you to support the people that we're working with. And what that would have done. So even though he totally did not mean to do this, wasn't even aware he was doing it, but this idea of the stigma that's coming from the people who are providing services for people is extremely prevalent. There's this, I've had this experience of feeling like that I was an inferior class of person because I am open about living with mental health, with mental illness, with substance abuse, as a suicide attempt survivor. And, and that gets us, to this sort of us, there's all you people who have their lives together. And then there's me, right? Which makes me less than, and that's, my own program, but this whole history of stigma that's taken place, even though there's all this evidence that peer support's effective, adoption of it has huge challenges in many ways. And I've seen it in play, and I've also seen it change. There's stigma from all levels, both from, the system as when you start looking at these horrible wage inequities, take the behavioral health profession and the wage inequities, but peer support in particular, it's hard to make a living wage as a peer counselor. And what does that say to people who are supporting people who have suicide attempt survivors on a daily basis? What's it like, when you're helping people transition out of the hospital to the community? This is not easy work, but because people who have in this profession have a long history of being paid less than, I'm making generalizations, but you can see how that works. And then there's the individual stigma, right? I have my own stigma. I have my own stigma about myself, which is part of what I was describing earlier, right? I am less than. I don't feel that way anymore. That's changed for me, but and you look at how it manifests, like I talked about wage inequities or language use, which is huge. Oh my God. Every time I hear somebody talk about, oh, she's a borderline, and it hurts. It hurts. She is not a borderline. She's a person who's learned to live her life the only way she could to get her needs met, the only way she knew how with what she was given. She is not her disease. And that language is important, right? And of course we label people. That's what we do. It's not like anybody's fault, but as a system, And as somebody in recovery, part of what I like to do is try to help people understand that when I hear language about that, towards myself, it hurts my feelings and it starts making me feel less than, or there's an us versus them, right? And so, looking at stigma, this is important stuff. And we need to do it not just when we're talking with somebody who's living with this type of condition. We have to do it when we're talking with each other, right? It needs to change. Sometimes I say, there's slurs about, I'm a gay man, and there's terminology that we wouldn't use today that somehow that kind of language, if you're talking about a mental health disorder, can be more acceptable. And it's like, we've got to change that. There's also the experience of sort of appeasing. Yeah, it's like, oh yeah, peer support's great. Peer support's great, but I'm going to do the real work, right? And that's, so there's this sense of, yeah, I think I said it well enough there. And then working in stigmatizing environments, I hear this from over the years. There's always people in every clinical setting that I've worked in who talk down to the people they're working with, who try to control the people they're working with. And, and these environments for people who live with mental health conditions are challenging because it's like, they're talking about me, right? And that way they're talking to us like a parent talking to a child. It's like, I'm not a child. This person they're helping is not a child. Why are they treating them like a child instead of an individual? I get kind of passionate about this stuff, so forgive me. I don't mean to criticize anybody, because we grow up, we are part of the system that has made this, that has brought us to this point in this day. But what I'm saying is, let's challenge each other to try to make a difference. And there's all these different reasons like burnout, and that's understandable. There's some really amazingly challenging situations and people and individuals that we work with. There's also challenging staff people we work with. But anyway, so I told no blame. I understand, and I want to encourage people to think about their actions and their words, and advocate for change wherever you can. I just get going. So developing, we're almost, I need to hurry. I was talking. Anyway, developing peer support programs. I've done a lot of this at Harborview Outpatient. I helped start a number of different programs within the agency. Then I helped start the Peer Bridger program, the Western State Hospital Peer Bridger program. In all of this, and I don't have time to get into all of this, like, would be nice, but the idea is, you can't just hire peers and put them in and say, do your job. That doesn't work. Happens a lot. The idea is you need to have a plan. What is it? What kind of barriers are they going to have? Don't just start from scratch. There's a lot of programs that assistance, learn, plug and play doesn't work necessarily. The idea that buy-off has to happen both from leadership and it has to happen from other staff, right? So, leadership has to be on board and has to be an advocate, and it can't be this this idea that it's lip service to what it is, right? Learn about recovery values, recovery principles, teach your staff to them. If you don't have people on board in this way, there's going to be stigma, there's going to be failure, there's going to be, it's like there's all of this stuff has to happen, and there's going to be resistance to change. People are going to go, wait a minute, especially organizations that have never had peers working for them before. It's like, we can't have them doing this. I remember starting one of the Peer Bridger programs, being in a meeting where people are like, what do you mean they're going to be in the clinical team meetings? we can't have them there. We're going to have to change how we talk about people. And it's like, okay, that's not necessarily a bad thing. But anyway, so the whole idea is you also can't just dump it on people. You have to help bring them on board. You have to listen to people's concerns, listen with understanding, and try to help them understand what it is you're doing and why this is something that's going to not impose on them, but it's actually going to help them and help the people that you're serving. You know, that's this balancing act. You know, if you don't want to push too hard, you also have to listen. And you have to be persistent, because you can't just let them, you have to make it happen, right? So there's always pushing that needs to happen. So it is really an interesting dance of educating and listening and getting buy-in. And then you find your heroes, the people who are the ones who are early adopters, if you will, who are believers, and then they can start spreading the message to their colleagues, and if it's done well. Supervising peers is a whole talk in itself. I don't have time to go into it. Peer, I was a peer supervisor for a lot of years, and I think there's bringing your own lived experience into your supervisory role and understanding about some of the issues that peers are facing in their work can be super helpful. There's a lot to say about that I don't have to get in time to, and I think the other thing is, like, really celebrate success, celebrate it publicly, let people know what a great job people are doing, and not just for peers, with each other, right? You know, we don't do enough patting each other on the back, because a lot of the stuff I'm talking about isn't just about peer specialists. It's about us as human beings in the workplace with challenging lives and challenging work, and a lot of pressure and not enough money. You know, funding, there's a whole variety of ways peer programs are funded. I have to say that our grant ends in November for the ERSP project. We need sustainability funding to keep it going. It's really successful. We don't have it yet. We're looking for gap funding, right? So it's like, okay, well, we might get written into the budget for the next year, but we have this 8 months that we need to fund. So how are we going to do it? So we go out to different groups trying to find money. So a lot of peer support programs are done, you know, grants and going out to different groups and different whether it's a BHASOs, whether it's the HCA or DOH acronym SOUP support. It is Medicaid reimbursable. Yeah, I don't want to take too much time with this because I want to get on to one other thing. Anyway, so the other thing that it's cool to point out that increasingly grants have requirement that peers are included. State programs are having requirements that peers are included. So more and more, this is not just an optional thing. It's more and more, it's a required thing, which I just love. And ultimately, it's a low cost, high impact program service. So the last thing here is about taking action. Stay in touch with your representatives. We heard about this earlier today. Thank you very much. And, urge your leadership to engage peers, to use peers. And, I've always said, include people with lived experience at all levels of decision-making. And, I was having this conversation with somebody yesterday, and it's like, yes, we need peers in leadership roles, right? I happen to be a mid-level leader, right? I know people are in higher levels of leadership who are open about having lived experience. We need people who are leaders who understand the stuff I've been talking about and build that into programs in a really meaningful way, as well as we need people at the table, as we've heard today, to have lived experience giving input to the programs that are being created to help support them. Addressing stigma, there it is again, because I can't let it go. Becoming a recovery champion, understand recovery values, principles, what it is. Think about your words, and celebrate resiliency, celebrate, it took me umpteen times to try to get my life together. And I'm a person in long-term recovery, and I have a husband, I own a house, I have wonderful family and friends and community. And, this is all stuff that if resiliency happens along the way, it's not a linear process, and we all are resilient. We show up to work day in and day out, we're resilient, right? Because we have to be right now in this world, we have to be resilient. And I think that's it finally. That only leaves about 5 minutes. I encourage you to reach out to me. Here's my contact information if you want to know more. Thanks.
Thank you so much, Topher. Okay, I've kind of summarized. There are 11 questions, but they're really 3 topics. So I've summarized, and I think we should be able to get through all of them just fine. First one is around people wanting to know about working in peer support, either in your program or around the state. Where should they look? How can they get more information about working in peer support?
In terms of finding peer support jobs, there's, it's just like searching for any other job. You've got to go out and look for it, right? Different, University of Washington, we have our website. With UW Hires, we have, every agency will have their website. You look for jobs there. In terms of knowing more about the profession, you can go online, look up peer support programs in Washington State. They have all the information about getting credentialed and what it takes to become a peer counselor, and do information interviews, talk to people who are doing the work, find out, be curious, start asking questions.
Okay, great. And who can use this program, the Harborview program? Is it available to youth, and does it require health insurance?
So great question. We right now, under the SAMHSA guidelines, we can only serve people who are 25 years or older. Should we get our sustainability plan, we'll hopefully be serving people from 18 and older. The Jasper app is not yet cleared. They're working on youth-oriented stuff, so I can't really speak to that. But that would be another chapter down the road. It does not matter if people have insurance or not, unfunded. We are, as part of the grant, it's payer blind, so we'll take anybody. And we are also open to referrals. So if you're interested in knowing more about how to make referrals, please contact me.
And I think people also wanted to know, do they need special training if they have lived experience? And if so, what?
Yeah. Yes, you need special training. I heard this term the other day, and I had to ask my boss, Melody, what was that term? It's experientially credentialed, right? So this idea that we have credentials and the fact that we have lived experience, but we need training in order to use that lived experience effectively, which is what the peer counselor training is about. We're looking at Behavioral Health Institute. Part of this workforce development program that was mentioned earlier is we are developing at the BHI apprenticeship programs for peers, SUDPs, and mental health techs, which will provide paid internships for peer counselors that should be rolling out in September of 22.
Okay, great. And Marnie from Forefront has chimed in that Peer Washington would be another great resource for that. The last category of questions is really about the app. People are very curious. So does it use artificial intelligence? Where can they get more information, and how can they get access? Who can use it, and how do they do that?
Well, great questions. And so Jasper Health, JSPR Health, is a tech startup. They sell the app to healthcare organizations right now for use in emergency departments, and I believe they're doing some pilots elsewhere. I don't work there anymore, so I don't know exactly where things are at. So that's the company. To use it we use it as part of our program because we license it from them to use. So we're offering it to people who are enrolled in our suicide support program. It's not just something you can download. You have to have been given access through the point of care in which it's offered. I don't know if I answered all the questions you had in there.
Yeah, I think you did. That's
Okay.
really mainly what people wanted to know. So they're going to look up Jasper Health to get more information.
jasperhealth.com. Yeah, jasperhealth.com.
Okay, great. And there was one last question: is people want to know if you are given sustainable funding, how do you see the use of the app developing in Washington?
That is a wonderful question. You know, right now we're looking, you know, we have there sort of pockets of our contracted providers. I would love to see this model adopted everywhere in the state, right? So sustainability could be really broad, or it could be sort of continuing what we're doing and continuing to increase our community referral capacity. The use of the app, I would hope would be part of it, just because I love the thing and I think it's effective. I think it's brilliant and I've seen it work. That doesn't mean that other digital technologies might also or be used instead of. So, you know, sustainability in my mind would be peer support combined with digital technology. Right now, it's being run through Harborview Medical Center. That doesn't mean that we can't use this model and have it run from different regions in the state with different funding mechanisms. It could be one funding mechanism that's divided regionally. It could be us providing in different regions, right? You know, so there's different models we could look at, and those are all conversations that we want to have with our wonderful legislators.